Good morning, everybody. So don't judge me for the title. This morning, as I went through my presentation again, I realized only one of these cars is still in production now. I don't know what that says about me and why I chose those as part of this title, but I'm at Scott & White, and so it's been a great residency, and it's great in PGY order, I guess, as I just realized too, from 2 through 4, and it's been, nothing has been a disappointment at all, getting to meet some great people, and, Dr. Henson, I followed him from Georgia to all the way out to Scott & White, and he really met expectations. But then there's this guy, Dr. Smith. He retired just before I start residency. I had to go all the way to Haiti just to watch him operate, so, and I'm trying to get over that. But these are my little kiddos, definitely their personalities. Anna Lynn is definitely a princess and gets whatever she wants, believe me. And then my son is all boy, so they get along real well. So we have a case of just dark and fuzzy vision in a 60-year-old female for the past few weeks, especially in the right eye, this kind of dark spot. Her past history, you can see she had ovarian cancer, hypertension, ocular history. Notably, she had an episode of just uncomplicated anterior uveitis a few months prior that resolved just with topical steroid taper. Otherwise, pretty unremarkable past medical history. So when she comes in the clinic on this presentation, vision in the right eye is obviously pretty poor. Left eye, not too bad, but no improvement there with pinhole. And she had history of just a little mild cataract. Pupils are normal, which at this point you're kind of, as a resident, scratching your head, be like, man, it's more of a home run if there was an RAPD, because then I know she's not faking it. Now I actually have to look for something. Pressure was normal. Anterior segment, there's a little bit of cell. Again, not a very significant cataract. So then we go into the posterior segment of the eye. The macula in that right eye is bowing out at you. And then you can see there's pigment stippling 360 degrees around the retina, and then snowballs OS. So this is a point where I like to stop and tell the patient, man, you are not crazy, and I'm not crazy about my vision testing I just did. We have a reason. You have actual snowballs in the eye. I don't know how she actually took that. Then there's a little bit of vitritis as well, OU. So her OCT 6 months prior, when she had that episode of anterior uveitis, it was uncomplicated, was pretty unremarkable, just kind of an incomplete PVD there, OS. So then today, you can see on this that there's a remarkable change on this presentation. There's what looks like immune complex deposition there in the outer retina on the right eye, and then also some changes to the outer retina. Left eye, not nearly as many changes at this point. Maybe a little bit of thickening, but the outer retina architecture looks pretty good. So at this point, we have poor vision in the right eye with some macular edema and immune complex deposition seen on OCT and panuveitis. So she was started on topical steroids at this point with a quick follow-up in 1 week. Comes back the next week. There's a little bit of changes. You can see some more swelling there on the right eye. Then on the left eye, a little bit of thickening possibly, and you can see a little bit of changes to the outer retina as well on these OCTs. Vision hasn't had much change. You can see the vitritis has gotten remarkably better just on topicals, but still hasn't resolved. But now we're seeing some changes in the posterior segment where we have this RPE atrophy and clumping instead of just the stippling that was seen 360. So what's going on with this patient? So there's kind of a vast differential. She had this anterior uveitis earlier, so is this just inflammatory? But she also has this history of gynecological cancer, so could that be it? She doesn't really have any family history of anything. So we get our uveitic panel back, and pretty unremarkable, not very helpful. Obviously, we know that a lot of times it is unremarkable and doesn't help us, but still, we hope sometimes, I think, that it'll show us what's going on. But this is unremarkable, doesn't really help. So she got some subtenon's Kenalog OU, comes back. We have the resolution of the uveitic picture looked a little bit better on exam with the cell going down a lot. But now we can see some big changes on the retina on this OCT. So the outer retina just looks terrible now, especially in such a short amount of time. There's a little bit of VMT there, but the outer retina is really what we're looking at. Then go into OS. You can see again there's some changes in the outer retina with a little bit of cystic changes there, parafoveal. So let's look at the posterior segment now. What do our pictures show us? So on the right eye, that is not a normal foveal reflex for Max and Jimbo. It's kind of weird. Usually at the grand rounds, we're trying to get our first years and everybody, and they're sitting right in front of me, so I'll try not to ask them questions. But this fovea, abnormal, it correlates with those immune complex deposition that we saw on the OCT. But otherwise, we don't see that stippling, but there's definitely some RPE changes as well in the periphery. It's hard to tell in this photo, but left eye doesn't look as bad, but you can kind of see, again, some perifoveal changes that correlate possibly to some immune complex deposition. So on autofluorescence, you can see it a lot better, that it highlights these lesions that are just strange. Left eye, you can see it a lot better than we saw in the color photo. So what do we have? Again, OCT with those immune complex, some changes in the outer retina. At exam, she was quiet. But what's concerning is the vision is still terrible. And going back as well, I didn't highlight the arteriolar attenuation a little bit that was not really evident when she first presented on posterior examination. You can start to see it here at OD, and then OS not as much, but it is a slight kind of more increase in the attenuation compared to original presentation. So let's see what the ERG tells us. A lot of red, that's what that tells me. There's a lot of, pretty much every category with scotopic and photopic responses, we have diminished responses in our patient. So that does help narrow our differential, especially now that we saw that attenuation. So it's down to CAR. So this was kind of an atypical presentation just because she had this episode of uveitis, this anterior uveitis a few months prior. And then everything was normal. Vision returned to normal at that time, didn't have any symptoms. But again, she does have this history of a gynecological cancer, which is common with CAR. And we have to remember, too, as ophthalmologists, that they can present with CAR before they even get diagnosed with a primary cancer. So this patient, it was a little bit easier because she already had the history of cancer, but that's just something we have to keep in mind. And small cell breast and then the gynecologic are the most common. The vitritis can happen as well. That's something when I first learned about this, didn't really think about. You think about, attenuation, boom, you have the flattening of ERG, but we have to remember that it can present in a variety of ways, and the fundus can even be normal to start with. It doesn't have to present just with those real attenuated vessels starting out. And these antibodies kind of good to know, but these are a very small subset of CAR patients that will test positive, so anti-recoverin is probably the most well documented, but again, it's just not super common. So how does this present? Again, our patient was a little atypical because she had that episode of anterior uveitis before, but it is this painless vision loss, and she did fit that picture. Didn't have as much of these positive and negative phenomena, and that correlates more to whether the rods or cones are more affected in the subset of patients, but rods and cones are typically affected. It can be bilateral, but it can still be asymmetric, so that's something to think about too. Don't just discount CAR because it's a unilateral presentation. So on exam, the RAPD could be there, but not necessarily, depending on the number of cells affected. And the normal initial fundus examination, that's what would definitely get me during residency. It's like, normal fundus. It's got to just be a straightforward uveitis, but that's something to keep in mind, especially with the patient history. So a significant thing about CAR is even counseling patients is a big part of this because unfortunately, you have to give them the talk that this probably is not going to get better, even with resolution or treatment of the cancer. We can calm down the eyes, get rid of some of maybe their discomfort from the uveitis, but there's not a very good visual prognosis with this, and you can even progress to the flattening of the ERG. If they have not been diagnosed with the cancer before and they have a presentation with type of CAR, just remember to consult out and get a workup for the malignancy. So, go dogs.